My name is Dr. Barbu, and I'm one of the movement disorder specialists at the University of Tennessee Medical Center. And I will be giving the introduction on Parkinson's disease for today's symposium. I have no disclosures. So I wanted to start with a quote by Michael J. Fox, and it says, I often say now I don't have any choice whether or not I have Parkinson's, but surrounding that non choice is a million other choices that I can make. And I hope you keep this quote in mind as we go through the slides. So, we're going to talk about the history, the etiology, the symptoms, the diagnosis, and treatment of Parkinson's disease. This photo here is a picture I took of the Atlanta Botanical Gardens. So, if you get an opportunity to see it, I highly recommend it. So, let's begin with the history. So, on this book on the right, the title is An Essay on the Shaking Palsy by James Parkinson, and it was written in 1817. He was one of the first people to describe Parkinson's disease. In this essay, he had 6 cases where 3 were formally examined. And what he noted were similar features between the cases. What he saw was a tremor at rest, so kind of a pill rolling tremor. He also noted a flex posture, so a stooped posture, a fascinating gait, and reduced muscle power. A fascinating gait shows up a lot later in Parkinson's disease, and what happens is you start to walk. Your walking gets faster and shorter and choppier, and it's kind of hard to stop. It's like you're going head first. Now, in terms of prevalence in the world, in 1990, there were 2.5 million people with Parkinson's disease. But then in 2016, it grew to 6.1 million, and this number continues to rise every year. Parkinson's disease is so common that it is the second most common neurodegenerative disease after Alzheimer's. Neurodegeneration meaning breakdown of brain structure and chemicals over time. In the United States, there are 60,000 Americans who are diagnosed with Parkinson's each year, and men are more likely to get it than women, about 1.5 times. Now, the majority of people with Parkinson's disease are much older. The biggest risk factor is age, but there's still about a small percent, 4% of people who develop it before age 50. And we call that young onset Parkinson's disease. So then we ask ourselves, what causes Parkinson's disease? And it goes to an area called the substantia nigra, which is located in the brainstem. The brainstem is right here and it connects your head to your spinal cord. And what we have noticed through research, and we're still trying to learn more, is that the substantia nigra, the cells inside there called neurons, start to break down and die. And their job is to produce dopamine. And dopamine is very important because it helps with balance and helps with coordinating movement. And so the loss of dopamine over time makes it difficult to do fine motor tasks. And this is what we've noticed in Parkinson's. Now, if you were to get a tissue sample of the brain with someone who has Parkinson's disease, what would you see under the microscope? And if you look at these pictures here, what they find are Lewy bodies right here. So Lewy bodies are pretty much an aggregation of misfolded protein called alpha-synuclein that grow and spread throughout the brain. And what they feel like is that as there's a breakdown of the brain and loss of dopamine over time, these Lewy bodies start to show up more and more on brain tissue. So overall, as we age, our substantia nigra and dopamine in general do reduce a little bit over time. And if you look at this image right here, as we all age, we're losing a little bit of dopamine. But if you have Parkinson's disease, you have an accelerated rate of dopamine loss, especially if it's young onset, showed by this red line here. By the time we develop our first motor symptoms of Parkinson's, being like rest tremor, stiffness, slowness, we've already lost 70 to 80% of our dopamine, which is a lot. But we not only form motor symptoms, we also form non-motor symptoms like difficulty with sleep, hallucinations, difficulty swallowing. And that's because there's other areas of the brain that form dopamine, and we're also losing other areas that form different kind of chemicals like GABA. So that's why everyone is so different depending on what's being lost and what areas are being affected. So we know what could possibly what happens when Parkinson's develops, but what causes it? And it's very complex. We think there's a combination of environmental and genetic factors. So these are certain things in the environment that could possibly increase your risk of developing Parkinson's disease. And those are pesticides, if you grew up on a farm or you worked at a farm, insecticides, drinking well water, things like this can put you at risk. There's also changes in your DNA that could put you at risk here. And this is just a short list, and this list is growing every year as we're finding more and more DNA variations. But besides those, there's also things that can reduce your risk. So if you look down here in the environment, tobacco smoking, even though I don't recommend it, coffee drinking, NSAID use like ibuprofen, calcium channel blockers here. These are used for blood pressure, alcohol consumption. These might reduce your risk of Parkinson's disease. There's also changes in DNA that can reduce your risk as well, shown here. So this table is showing that before you develop your first motor symptom, so here they put bradykinesia, and I'll go a little bit into that in the next slide. That's a slowing, rigidity, stiffness, and tremor. You develop certain non-motor symptoms years before that you never connect with Parkinson's disease until you form the first motor symptom, and you look back and you're like, oh, okay, I see the connection. But none of us think of that. If I have constipation, I'm not going to think, oh my gosh, I'm going to develop Parkinson's disease in the future, because that doesn't commonly happen. But what people might notice when they look back is years of constipation, years of REM behavior disorder. So that's talking, kicking, punching in your sleep. You're acting out your dreams. And sometimes bed partners can get injured in the process. A loss of sense of smell, maybe mood changes like depression and anxiety. So you might notice those years before the first motor symptom. So this is a list of motor symptoms that may develop. Not everyone gets them. So you might develop a tremor. The tremor is typically the tremor at rest, but you can also get a postural kinetic tremor. So when you're holding things, doing things with your hand, but typically is not as prominent as the resting tremor. You can also develop a slowness that we call bradykinesia. That one is if we see you in clinic, we'll ask you to do taps, open and close your hand, turn your hand like this. And what we're looking for is a slowness or a decrement in that movement. Another thing we look for is change in posture. So more stooped over time, as shown by this picture. But it's not only forward stooping, you can also be leaning to one side as well. We also see changes in gait. So gait gets smaller, it gets you're not picking your feet up as much as you used to. You notice issues with balance, and these can put you at risk for falls. Dyskinesias, those show up a little bit later. They're more like dance-like involuntary movements, so kind of like this. Some people may get the whole body, some people get one side, some people get only of their mouth, but sometimes it's mild and it doesn't bother you. Sometimes it's so significant that it's kind of gets in the way of your walking and you trip, or it's happening when you sit and you start to kind of fall out of the chair. You can also form dystonia. So that's an involuntary muscle contraction. What you might notice is toe curling, or when you walk, your foot is turning inward or outward. You can also develop motor fluctuations. That's later too. What you notice is when you take your medication, it takes a little bit to kick in, and it's pretty much wearing off before it should by the time you take your next dose. We have a lot of options for these motor symptoms, which I'll talk about. So here is a nice video on changes in walking as the disease progresses. So let me show you a few. So this is early stage. So as you can see here, very minimal symptoms. The stride length between the feet have shortened a little bit. The arm swinging is a little bit reduced, but overall looks good. Here on the left side, his arm swinging has definitely reduced, and that stride length has gotten shorter too. Here, that left arm has pretty much not really swinging, and it's kind of flexed in at the elbow. And you can see his walking is slower, and that stride length has shortened as well. Now this is mild to moderate. You can see here both arms reduce swing, slower in walking, reduced stride length. As you saw when he was turning, it took a couple more steps. Here he has to use his hands to get up. Stride length is shorter. You see he's not picking up his feet very well. Arms aren't swinging, his posture is stooped. This is advanced stage. So she has to use her hands to stand up. She needs the support of her hands. Walking is much slower. Arm swing has reduced. Stoop posture. See, it takes her several steps to turn around. And she has to sit down slowly. Here, it takes a little bit to get up. And when he turn around, he's starting to hesitate, and then he's going to have a full freezing of gait, and that's what we call it. Typically, if that happens, we do recommend stopping where you are. Don't try to push through it because you increase your risk of falling. But there's techniques to break it. So what you can do is lean from one foot to the other and say 1, 2, 1, 2, or you can say in your head big step to help break that freezing. But physical therapy will teach you a lot of these techniques too. Here he's using a cane, arms aren't swinging. There has to be people around him to make sure he doesn't fall. He's much slower, doesn't pick up his feet very well. Same here as well. Here he's freezing right when he starts to walk. So this can happen too. It's not just the turns, but it can be when you start to walk. And it typically happens in very tight areas like a house. But if you were in an open field, the chances would be less to freeze. Okay. So not only can you form motor symptoms, you can also form non-motor symptoms. And you don't form all of these symptoms. Some people get some people don't get many. And what can happen is your sleep can change. So it's hard to fall asleep, it's hard to stay asleep. You can get the REM behavior disorder we talked about. You can also have mood changes, depression, anxiety. The apathy here is describing more lack of motivation. So the hobbies that you used to love to do, like golfing, you don't feel like doing anymore. Hanging out with your neighbors and friends, you don't feel like it as well. You can develop impulse control disorder. Those are more compulsions and obsessions with something. So it can be like shopping you're obsessed with, gambling, sexual behavior, or staying up all night doing a project, and it's hard to stop and go to sleep. You can also develop, fatigue during the day. You can develop hallucinations. Hallucinations are different for everyone. Some people have the mildest form that we call passage hallucination. It's kind of a shadow that you see on the side and you look and there's nothing there. Some people have forms, so animals, people. Sometimes these hallucinations don't bother you because it could be, a dog that had died in the past and you miss your dog. I had one person who would see a Papa Smurf on his alarm clock, and that didn't bother him at all. But for some other people, the hallucinations can be really frightening. Also, change in sense of smell that we call hyposmia, difficulties with short term memory, with concentrating. If you're watching TV and someone comes to ask you to do something, you might miss both because you're able to focus on one thing at a time. So one of them must be turned off for you to give your full attention. So if you're in a crowded room or at a party, sometimes you feel a little anxious because there's too many things going on to focus on. You can also develop orthostatic hypotension. That is when you go from a sitting to standing position and gravity makes your blood pressure pull to the ground. And so it's your body's job to kickstart your heart and your blood vessels to get that blood pressure back up. But in Parkinson's, that sometimes slows down or it never happens. And you can get all kinds of symptoms with it. You can feel foggy, hard to concentrate, lightheaded, dizzy. You feel like you have to take a moment before you get up, kind of a imbalance. And so for that, there's treatments that we can do. And Parkinson's disease over time will lower your blood pressure. So if you were someone who had high blood pressure and you were on multiple blood pressure medications, later on you might have to reduce or come off those medications. You can also have problems with drooling. That's typically at night a little bit. Some people do get it significantly during the day, and so they constantly feel like they have to dab at the corner of their mouth. Swallowing can be difficult as well, constipation, frequency in urination, accidents with urination. You can also get sweating. So a lot of people will have profuse sweating early in the morning before they get up. So various symptoms, but keep in mind that you won't develop all of these. Everyone's different. So now that we know the motor and non-motor symptoms, how do we diagnose? So Parkinson's disease is still largely a clinical diagnosis. And when we're talking to you in clinic, we're kind of getting pieces of your history. We're looking at your exam to see if you meet criteria. We do have testing like DAT scans, skin biopsies to help support the diagnosis, but the accuracy is still going to come from the clinical exam. And what we look for first is something called Parkinsonism here. That's an umbrella term. It's like calling someone a headache. But what's the cause of the headache? Is it a migraine? Is it a stroke? And so when we call someone Parkinsonism, we're noticing bradykinesia on their exam, which you must have. So that's that slowness in movement, plus either rigidity, that stiffness, or that rest tremor. And so once you meet the diagnosis of Parkinsonism, we have to ask ourselves what's causing it. Have you had many strokes in a particular area where Parkinsonism can develop? Or are you on a certain medication that's causing it? Or do you have regular Parkinson's disease? For regular Parkinson's disease, we look for certain features that are supportive. So if you look on the right side here, we want to see if you respond to carbidopa levodopa, which is the pretty much the golden treatment for Parkinson's disease. We also want to see with the longer you have the disease and being on levodopa as well, we want to see if you develop dyskinesias, those involuntary muscle movements like this. And we're also looking for documentation of a rest tremor, and sometimes they'll do some tests to see if you really have lost your sense of smell. Things that are red flags to us or tell us you really don't have Parkinson's disease are cerebellar signs. So in the back of our head, we have the cerebellum, and that's in charge of balance. And so if there is involvement on the exam, more or less likely that you have Parkinson's disease. We also will look at your eye movements, and this supranuclear gaze palsy is restriction, mostly in vertical position of eye movement. So you're looking forward, but it's kind of hard for you to look up without moving your head up, and it's kind of hard to look down. And a lot of people complain of double vision, so that's less likely in regular Parkinson's disease. Other red flags that we look for is if you have early gait issues and you are progressing much faster than we would expect for Parkinson's disease. That will point to more of an atypical form. Or the opposite, you haven't had any progression at all, and that might point to more of a drug induced Parkinsonism. So there's a lot of things that we look at. Okay. So let's say you get diagnosed with Parkinsonism. Is there certain medications that you need to avoid? And it's yes, because some of these medications will block the areas that dopamine binds to and make your Parkinsonism worse. So in the anti-nausea family, Phenergan, Reglan, Compazine, these medications can block dopamine and cause Parkinsonism to get worse. Also, if you have a history of bipolar disorder, schizophrenia, or you have severe depression, sometimes people will use certain antipsychotics to treat it. This is a very short list. There's a lot more than this, but if you get put on Haldol, Risperdal, or Abilify, these can worsen Parkinsonism. So sometimes we have to switch to other treatment that have a less likely chance of worsening Parkinsonism. So let's say, now you're diagnosed with Parkinson's disease. Then what? The first step is, acceptance. That isn't easy by any means. It's very difficult to be diagnosed with Parkinson's disease. What's best to do is to try to, read up on it, ask your movement disorder specialist to tell you more about it, talk about it with your family, with your friends, reflect back on your life, think about the future. What are your goals for life? How do you want to have the best quality of life? Because once you reach that point, then you can move on to the next steps. Do keep in mind that Parkinson's disease is slowly progressive, which is a good thing. Everyone's progression is a little bit different from each other. That is true. There are many treatment options from like early, middle, and late stage Parkinson's disease, which is excellent. And there's things you can do to control the disease process. So knowledge is definitely key. The more you know about Parkinson's disease, the more you can anticipate certain things, make lifestyle changes so that you have the best quality of life. Also, exercise, very, very important. We recommend 4 to 5 days of exercise for at least 30 minutes. And it has to be something that gets your heart rate up, like moderate cardiovascular exercise. And it can be anything. It could be running, walking. Some people have a really bad back or they have a lot of knee pain. And so there's other ways. For example, you can use a stationary bike or swimming that puts less pressure on those areas so you can get in your exercise. Because what I've noticed is that people who exercise and those who don't, there's a very large difference between them. The people who exercise, they move better and they have better non-motor symptoms too. So less, issues with constipation, they sleep better, their mood is better. So exercise is very important. Nutrition as well can be helpful. You definitely want to make sure, you don't develop diabetes, or if you do have it, you keep your glucose levels very low. It's very important for the overall outlook of life. Support is important, getting support from neighbors, friends, family, in case later on you may need help for something or try to get to your appointments, you have that support system to help you. Attitude is very important too. Once you're able to accept the diagnosis, it's important to have a positive outlook and hope for Parkinson's disease, because I'll go a little bit later into all this research that's being done on it. So hopefully we'll get to that cure much faster. So once again, knowledge is power. Exercising is very, very important. I don't know how to stress this enough. Building your support system is important, but not just that. In terms of, from a medical standpoint, having a movement disorder specialist, if you're able to get to one, having physical, occupational speech therapists, joining a support group, all of these, you're building your treatment team so you can get the most support that you can. Healthy diet, once again. Also participating in research. Research is important because this way we get to know more about Parkinson's disease. And as we know more, we can tailor treatment and think about treatment from different avenues to hopefully get to a point where we can slow down and cure the disease. There are resources nationally that you can look up. These resources can talk to you about support groups, information, new drugs that are coming out. So we have Parkinson's Foundation, Michael J. Fox, Davis Phinney, and the American Parkinson's Disease Association. But not only nationally, we also have local resources right here in Knoxville. So we have Peterson for Parkinson's, PK Hope, PJ Parkinson's, Vanderbilt Person, and Rowan area. These are great resources. They hold exercise classes, they have informational meetings, they keep you up to date on everything. So definitely highly recommend these support groups as well. So let's talk about research. So in the year 2021, and with COVID happening right now, there's still a lot of research that they've been able to push forward and keep going with, which is great. What we have right now is 142 clinical trials that are registered. And what they're trying to do is figure out treatment strategies for Parkinson's disease. So we have 34% of these trials are in phase 1. Phase 1 is early, and they're looking at the safety of the drug. Phase 2, they have about 46% here. And in phase 2, what they're looking at is how high of a dose can we give someone where the benefits still outweigh the risk. And that's what they're looking for. In phase 3, it's towards the end. And here we have 20%. And they're reaching the point is, okay, we know the safety, we know how much to give. Is this drug making the change that we're looking for? Are their symptoms better? Is the progression slower? And so what you see here as well, about 42% of these trials are looking at long-term disease modifying therapies. So they're looking at slowing the progression of Parkinson's. And then 58% are focusing on symptoms, so the tremor, the slowness, the stiffness. And then also 34% right here, they're looking at repurposed therapy. So what that means is there are medications out there being used for like migraine, for seizures, but what they find out is, it has benefits that can help Parkinson's disease. And so that's what kind of studies they're doing. If you want to know of any research in your area or around you where you can participate, these two resources are great websites. So clinicaltrials.gov right here, and then Michael J. Fox right here. So what you do is you go on the website and they have a search bar and you write down your disease. And then they give you kind of a radius of mileage of how far you're willing to travel to participate in that research. And then you click search and it populates a bunch of clinical trials that are open or closed or they're still looking. And so you can see what they're doing and see if it fits what you're looking for. So now on to treatment. So we went over history, went over prevalence, we went over symptoms, research. Now we're going to look at the treatment. At this moment in 2021, the treatment is only helping the symptoms. We don't have anything right now that slows or stops the progression of Parkinson's disease. But as you saw, we have a lot of clinical trials in phase 3. So cross fingers, one of them finally does it. And so, what we think about when we see you in clinic is trying to individualize low doses of different medications to help your symptoms. And this is important because, say, for example, you go to a support meeting and your friend there says, "Hey, I'm on this drug and it's really helping me." Ask your specialist if it'd be a great option for you. And we definitely want to hear that because what we then do is look at your current symptoms, your goals for life, the medical problems that you have, and we look to see if this certain medication fits you. And everyone's different, so we have to keep that in mind. Also, timing is very, very important. The gold standard of treatment, carbidopa levodopa, has to be given at timely times. And the reason for this is because if you try to take the medication based on when your symptoms get worse or when you have time for it, you increase your risk of developing those motor fluctuations and the dyskinesias. So it's important to keep the timing as close as you can. If you ever get hospitalized for like a urinary tract infection or a stroke, make sure that the staff is giving your medications on time as well, because that will give you a better outcome during your hospital stay. So we're going to look at the disease as it progresses over time. So we know as Parkinson's advances, the amount of dopamine in your head starts to get less and less. And because of that, that sometimes will get in the way of how well your carbidopa levodopa will work. Also, people will start to develop wearing off in terms of motor fluctuations. Wearing off is when your medication wears off and you notice more tremor, more slowness, and more stiffness. You could also develop dyskinesias, and also the patterns in your gastrointestinal tract can change as well. So if you're very constipated or you have bloating or you don't absorb things very well, the medication can be sitting in there and not being absorbed like it should, or it starts to get absorbed way later in the day. And so with that, things like medication used to kick in much faster, but now it's slower and it's wearing off before the next dose. But fear not, we have a lot of medications, and this list is growing, to help with all those symptoms. So first here is monotherapy. So we have carbidopa levodopa. What it does is that it travels to your brain and gets converted into dopamine, which is what your head is lacking. And we have many formulations. We have short acting, we have long acting, we have a combination of both. We also have dopamine agonists. These pretend to be dopamine, and what they do is they go inside the brain and they attach to areas that dopamine attaches to help with your movements and balance. We also have medications here. So this is the MAOB, and we have COMT inhibitors here. What they do is that many times that chemical dopamine gets broken down after a little bit inside the head. So what they do is they help prevent that breakdown, try to keep it in the head as long as possible to get benefits. Here we also have amantadine. This actually used to be a medication used for flu. And so that's where the idea of repurposed drugs comes from. Amantadine is fantastic because it's good for motor fluctuations and great for dyskinesias. And we have short and long acting versions. Here, if you're developing motor fluctuations, we have a list of medications to help. This duopa here, I'm going to talk a little bit about it in the next slides. But we have something called rescue medications. So this is when you have already tried medications to help your carbidopa last longer, but you've reached a point where you still have that hour of wearing off before the next dose. And so you can take one of these medications to give you that short boost to help bridge that 1 hour until when it's time for the next dose. So you have subcutaneous, so injection, or sublingual, dissolves under the tongue, apomorphine. You also have Ambrosia here, and that's where you inhale the levodopa to help with off symptoms during that time. For dyskinesias, not many options. Well, I'm going to talk about the procedures like intestinal infusions and deep brain stimulation, but one of the few medications that we have is the amantadine to help with that. So those were the oral medications. Now we're going to talk about different procedures that we have. So this first one is duopa. So if you look at the picture here, he's got a pouch here. People can hold the container in different things. So you can use a fanny pack. Some people use a vest. Some people use a bag. But inside this container is carbidopa levodopa, and is continuously given through this tube right here, connected to your stomach. And what's nice about it is because you're getting the carbidopa, levodopa continuously, you're having less dyskinesias and off times. And then at night, you turn it off to get a break from it. So sometimes people at night will take like an oral carbidopa, levodopa to give them a small bridge in case they have to wake up to use the bathroom. The other thing with it is if you swim or shower, you need to take it off. So if you're swimming, you can also take an oral carbidopa, levodopa, do your swimming, and when you're done, connect the tube back. And they did a 12-week study on Duopa, and what they found out is that off time improved. So from 4 hours to 2.1 hours. Also, on time without troublesome dyskinesias got better as well, and it got reduced by 1.8 hours. So there's a lot of benefits there. One thing to be careful with, you have to make sure you keep it clean because it can get affected. If it gets blocked, you'll then have to get it unblocked. So it does require a lot of support to help. We also have deep brain stimulation. So what that is it is brain surgery, but what they do is they make two small holes on either side of the head, and with a skinny little lead like this, with imaging, they put it in the right spot. And we have two main targets that we use. One is the subthalamic nucleus, and the other one is the globus pallidus interna. We do have a third one here called the thalamus, but it helps more with tremor. It doesn't help with the other symptoms of Parkinson's, like dyskinesia, slowness, and stiffness. So once they put the lead where they want it to, it's connected to a wire that goes under the skin, behind the ear, down to the chest area here, into a battery. And it looks just and feels just like a pacemaker. And so what I can do is then with my computer connect to it without a wire and create this electrical field to help control the tremors, the slowness, the stiffness, the dyskinesias, the motor fluctuations. Now, do keep in mind, even though we have it in the target, depending on how big I make that electrical field, I could target other areas outside it. So you can get side effects like tightness, tingling, a weakness. But the nice thing about deep brain stimulation is I can change the shape of that field and direct the current in different areas to make those side effects reversible, which is nice. Also, there's more studies coming out, but we can't guarantee it. But there's studies showing that some of the non-motor symptoms improve as well. So there's some studies coming out that it could possibly help depression, anxiety, how you sleep, how you smell, and how your gut works overall. So this is one of the last procedures. So gamma knife and MR guided focus ultrasound. So what happens here is you lay on this system and you go inside a machine here. Kind of looks like an MRI. Pretty much is an MRI. But what they do is with a beam of focus ultrasound or gamma knife, they go there and they burn those targets that we were talking about to help with like tremor, slowness, and stiffness. And the benefit is much better if they are able to burn a little bit more tissue. But there is one catch with it, because if you're not careful on how much you burn, you may touch other areas in the brain that help control your strength, what you feel, and so you can get side effects. So about 20 to 30% of people could get side effects from this, and this ranges from imbalance, weakness, and numbness, tingling. A lot of these symptoms get better and they go away, but there's a few that's persistent. But this is still a great option for people who can't get deep brain stimulation because they have so many medical problems. And so this would be an option for them. Okay, so we talked about the motor symptoms. Now we're going to go into the non-motor symptoms. And this is kind of a small list. There's more than this, but I wanted to show you a few. So for anxiety, we have treatment for it that ranges here. For psychosis, this is more like hallucinations, delusions, paranoia. We have medications to help that. PD dementia, a few amount of people who have Parkinson's disease may develop Parkinson's disease dementia. And so we have medications here to help. We also have medications for REM behavior disorder. That's the dream enactment that I was talking about before. If you're very drowsy during the day, some of our medications do cause that, but there's a stimulant called modafinil that can help. If you have that orthostatic hypotension where your blood pressure drops, we have medications to help boost that blood pressure. Medications for constipation, medications for bladder dysfunction, for drooling, we have it. Some of these medications for drooling can affect cognition a little bit. So if that's a case or we're worried about that, we do Botox injections. And so we target the Botox injections on the salivary glands to dry them up so you don't drool as much. And then apathy, which is that lack of motivation, there's treatment for that. If there's a combination of depression and apathy, there's medications to target both. Do keep in mind apathy is difficult to treat, so not a guarantee with these medications. Also, there's treatment for dry eye syndrome, such as artificial tears. Remember that you will not get all of these symptoms. So, in summary, each individual with Parkinson's disease is unique and you have different motor and non motor symptoms. So, everyone's different. Very important to build that multidisciplinary team and find a support system in your community. Also, keep in mind that the treatment we have for motor symptoms are helping the symptoms. They don't slow or stop the progression at this time. But as you know, and as I said before, there's a lot of research in phase 3, so I'm hoping that will change. Once again, exercise very, very important. Also, for non-motor symptoms that we've talked about, there are conservative ways to treat it before we go towards medication. So, for example, for the drooling, conservative ways to help is chewing gum or mint. That can help a lot. Also, keep in mind that when you see a movement disorder specialist, we are looking at your current symptoms, your exam, your medical history, your goals in life, so we can tailor a kind of treatment that's very individualistic towards you. So now we ask, what is the future of Parkinson's disease? So, as I said before, there are multiple medications in research development, and they're looking at helping the symptoms or helping to slow the progression of the disease. And these are a few classes that they're doing on. There are more classes than this. One is targeting alpha synuclein here. If you remember before, I said if we looked under a microscope, we would see Lewy bodies. Inside there are those misfolded proteins called alpha synuclein. And so they're trying to target that to help slow the progression or the spread of alpha synuclein. And the hope is that if we reduce the amount of alpha synuclein in the brain, are we going to slow progression? Also, they're looking at glucagon like peptide 1 agonists. This is a type of treatment used for type 2 diabetes. There are now some studies coming out seeing a connection between if you have type 2 diabetes, you have a little bit more risk of developing Parkinson's disease. And so the medications used to treat type 2 diabetes can calm down neuroinflammation. And so they are thinking that maybe this could help with slowing the progression of Parkinson's disease. Also, as we're doing more genetic studies and learning about all these DNA changes, we are making therapies that target specific genetic changes. And so here we have LRRK2 and glucose cerebrositis. So a lot of exciting things coming out in the field of Parkinson's disease.